All right, shall I go? All right, okay. So today I'll try to talk to you about cardiovascular PET, the basic principles and current applications. So try to make this interactive and we'll move on. So let's start with the anatomy. Obviously we start with anatomy and physiology. So we're going to start with the anatomy of the PET scanner. Is this a PET scanner that you see here or no? These two are PET scanners or no? Yes? Yes or no? Well, the title says SPECT CT, so it is a SPECT scanner. So first I'm going to try to give you a little bit of the differences between the PET scanner and the different energy, and we utilize different crystals so that we are able to capture the information about perfusion in these patients or about where the uptake is. So you already had a CT lecture. In CT, what we do is that there is a radiation source that will emit the X-rays, it will pass through the patient, and then we capture it from the back on the detector. So you have the X-ray tube and you have the detectors. On nuclear, the concept is that you inject the patient with the radiotracer, and then you have the capture of the radiotracer by these detectors that can be positioned by SPECT, like in front of the patient or on the side of the patient, or like what we get here when we get it around the patient on the PET CT. So this is the PET CT machine that we have, and we're going to dig a little bit deeper into what's inside the PET machine. So when you open it up, what do you see? So this is a different model of the PET CT, and this was a prior machine that I worked on from a different vendor. So when you take it out, this is how it is delivered to your site. So this is how the machine comes in. When you take the cover, what you see is that it has two components. It's a PET and CT, similar to when you say SPECT CT. There is a SPECT and CT machine. So we're going to focus first on the PET part, because the CT part was already discussed by Dr. Cheng a few weeks ago, where there is an X-ray tube and there is the detector. You emit X-ray and you detect it on the other side by the detector. While on PET side, when I zoom a little bit more on this, now you see these rings here that are around the patient. So in comparison to SPECT, where we're imaging the patient from the front, now with PET, we have a full ring of detectors around the patient. So if I zoom a little bit more here, now you see these rings. So each one, you see this small square there, and each square has an imaging unit. So let's go dig deeper even and try to understand what's in that unit here. So what you have are three things. You have first the detectors, which will have the gamma photons coming in. See if I can get the mouse here. So you get the detectors here, which capture the gamma photon. Then it gets amplified in the photomultiplier tube. And then there are the electronics that will send it back for processing by the component of the electronic system. So a machine will have the scintillator or the detector. It will have also the photomultiplier tube and then the electronics. Same concept with SPECT, same concept with the receiving end of CT, and same concept with PET. You have the crystal that will get the photon, then it will go into a photomultiplier tube to get amplified, and then you go ahead and send it to the electronics for processing. So if we look in PET, what are the crystals that we capture? So this is for those of you who are going to be studying for nuclear board. They like to ask these questions. So for SPECT, we mostly use sodium iodide. So it's simple salt, sodium iodide. And this is kind of has been the crystal that we've been using for many years. So all the SPECT machines that we have, depending whether they are SPECT or SPECT CT, I would say 99% of them are using sodium iodide. There's a new crystal that came out recently which is called CZT, which is a different crystal. But most of the SPECT machines are sodium iodide. With PET, we don't use sodium iodide. We either use BGO. Let's see where the mouse is. So the second one, the BGO or the LSO. So our machine here is LSO. It has better efficiency. Depends on, usually with BGO you need higher energy to capture, but LSO is now becoming more of the standard for these. So the newer systems that we are using are mostly using LSO. So these are the different crystals and types. And this is the most expensive part of the machine. So the crystals are the most expensive part of the machine. So what I showed you here is that you have rings. So under every ring here, you see there are a box of crystals, and then under it there will be multiple crystals that are sitting in there. If one is defected, then like service will come, take it out and put another one. So you cannot have a defective one when you are capturing images. So after a photon is coming in, now it's going to go through the photomultiplier tube, because when the photon comes, it emits light, and this light has to be amplified. So similar to what you see here, it goes from one end to another to make the singular more intensified, and then we can capture it by the electronics and send it to where it's coming from. Nowadays, we live in an era that we have digital PMTs. I'll show you later. The other thing is that before, many years ago, they used to be able to localize where that signal is coming from. They used to put septae in front of the detectors. So if you put septae in front of the detectors, these LED septae will make it easier to localize where that signal is coming from, but you're going to be losing a lot of other signals. So this is how a 2D PET scanner would operate. But to be able to operate a 2D PET scanner, you need to inject higher amount, because many of the photons that you're going to be generating are not going to be captured by the detector system. So you will see later on when we talk about the radiopharmaceutical, the older system will require more of the radiopharmaceutical. The newer systems will require less of the radiopharmaceutical. So the other big breakthrough that happened probably about 5-6 years ago in the era of imaging is that now we have moved from the real photomultiplier tube to a digital photomultiplier tube. What does that mean? So you can see here, this is how the old unit. So under each unit, when you have that ring I showed you, under each one you have the crystal, the photomultiplier tube, and the electronics. Now under it is only this small one, which is to the right of it, and that photomultiplier tube is digital. So now we can amplify that signal digitally. What does that mean? Clinically, you can inject much lower dose and then image the patient with the same image quality. So you have better image quality. Or if you inject the same dose, you just need lower imaging time and get the similar quality there. So now, compared to SPECT, you have the two detectors. For those of you who rounded on 409, when you go and see, you have two detectors and they are moving around the patient, right? But in PET, we don't have anything rotating around the patient because the patient is fully surrounded by a full circle of detectors. So what's happening here? Why do we need detectors that rotate around the patient in SPECT, but in PET we have a full ring of detectors? It's mainly because of the physics of PET. With PET, when we inject the radiotracer, a positron is emitted, then it moves a little bit of a distance, and then it annihilates. When it annihilates, it gives two photons at 180 degrees. So technically, for every positron, you have 2 photons that are emitted on both sides. So to be able to account for them, one of the ways that physicists account for them is that you have to have 2 photons hitting at 180 degrees in the full ring. So you're not rotating the patient, then you're not rotating the detector, you're just detecting 2 photons that are at 180 degrees. So this is exactly how it would look. And they should happen very close to each other, otherwise we will consider them random events or scatter. And that is measured in nanoseconds. So when these detectors, because these photons, to localize an event, we need to measure them within nanoseconds. And that's why we have something called time of flight that will try to get rid of the noise. And if something is falling outside that range that you specified in nanosecond, then it will go away. And this is exactly the concept. Now somebody can argue that what you see here is a true coincidence on the upper left where it's a true event. But sometimes you can have a scatter coincidence where if 2 scattered, but they could potentially end up on what looks like a straight line. And this could be a mistake that this computer has special algorithms that should be able to detect it and reject it. Another way is that you could have a random coincidence, as you see here. One of them is like going upward, the other is going downward, and the software may potentially, or the machine will put it where it's coming from the wrong place. But there are also some algorithms that should potentially help in getting rid of these. Another major difference between SPECT and PET is the issue of attenuation correction. So for those of you, again, who rounded on 409, you know attenuation correction is in SPECT is optional. It's preferred, we like it, but you can do a study without attenuation correction and you can interpret it. Sometimes it will be hard if you have a lot of artifact, but it's not impossible. With PET, you cannot read a PET without attenuation correction. PET by default has to be attenuation corrected for different reasons. One of them is that the different photons are moving different distances. But one thing you need to know, all PET images are attenuation corrected. We do not look at non-attenuation corrected images. In fact, even sometimes we reconstruct them, but we don't send them, we don't look at them, except in very few cases like FTG infection studies and others. But for perfusion studies, all attenuation correction, all machines are attenuation corrected, or images are attenuation corrected. And so how do we do attenuation correction? So many years ago, before my fellowship days, there were not much CT attached to PET. So they were doing it with a transmission source. So the patient would be in the PET scanner and there is a radioactive source rotating around the patient and creating an image. And that could be germanium or cesium and other sources. Right now, companies do not make these. You might go to a place that still have some of these, but they are refurbished and they're becoming less and less in the market, and soon they will not be available. So if you want to go now and buy a PET machine, it will be most likely a PET CT machine. And CT is very efficient in doing attenuation correction, very helpful, and that's why we call it a PET CT. So it's technically a PET machine on the front and PET machine in the back and CT machine on the front. And the CT machine can be, like, for example, our machine is almost a 128 slice. So you can do a coronary CT angiography on it. You can do a calcium score. Some machines, like our SPECT machine, is only 2 slice. So you can use it primarily for attenuation correction. So most of the PET machines now, that if you want to buy a new one, you go to any company, they don't have except PET CT. And some of them will have a PET-MR machine, which is still growing. It's still a promise. We're still trying to find out where it's helpful. And the PET-MR machine, they will use the MRI for attenuation correction. And this is going to be still a challenge in cardiac, and it's not widely utilized for that. Okay, so this is how you do. When you do attenuation correction, whether on SPECT or on PET, you could potentially fix artifacts, but you could also introduce artifacts. So all of you know, when you read with us, you could get some artifacts when you do this. And part of it, the most common artifact is misregistration artifact. What does it mean? Because the CT is acquired separately and the PET is acquired separately, you have to fuse the images. So if the patient moved in between, even though it's very quick and seconds, then the images may not fuse, and what you correct is really an artifactual one. So when I was in fellowship, there was no remedy for that. The only way is to go back, beg the patient not to move, and retry it, re-stress them, re-attempt it that he doesn't move, and pray that that happens. Now all vendors have a software that on the machine, if you recognize that, you go and tell them, you just go tell the technologist, can you reposition it? We call it here reprocess. You can take the transmission and emission data and put them on top of each other again and try to fix that misregistration manually. Here's one example. You can see that there is an anterolateral defect. Everyone could see that. You can see here that the lateral wall has less counts compared to rest. But when you look at emission and transmission, you can see that the heart is not where it's supposed to be. And this again is not PET specific. This could be PET, this could be SPECT. So when you go back and tell the tech to fix it, now it's a normal study. So we do not want to introduce artifacts by doing PET, CT, or hybrid imaging. We want to make sure that the basic QC is well done and well accommodated. So these are the main differences between PET and SPECT. So the photons that are emitted in PET are 511 keV compared to 140 keV with SPECT. We acquire a list mode, so that's why we are able to do blood flow, and we usually get a good quality study. That's why what we see here, more than 3 million counts per second, and it's a very sensitive system, so that's why you get the PET CT is a very sensitive, especially the digital ones are very sensitive. And spatial resolution depends on many things, but you get much better spatial resolution with PET compared to SPECT. And in some cases, in some radioisotopes, I'll show you later, it may be on par with other cross-sectional imaging. Before we go to PET radiopharmaceuticals, any questions? Did I put you to sleep or not yet? Any questions? Salim, you don't have any?
Physics are hard.
It's hard?
Physics are hard.
Yes, sir.
Are there any instances where you would prefer SPECT over PET, or is that falling out of favor in the
Any what, sorry?
Any instances or indications where you would favor SPECT over PET?
Well, I'm going to cover that in the upcoming one. That's for MPI specifically. Anything else about this one? All right, so what are the radiopharmaceuticals? Anyone knows what are the SPECT radiopharmaceuticals? What do you inject every day on 409? Technetium. So that's probably the most common radiopharmaceutical we use. It emit, so we can attach it to MIB or tetraphosphine and get the images. Before, many years ago, we used to use thallium. For the past year, thallium has not been even available in the US because the market has gone down and the industry decided that this is not something they want to go with. So these are the main differences between the radiopharmaceuticals that we do for SPECT and PET. So in 409, you could buy a molybdenum generator, milk it every day, and get all the technetium from it. You cannot do that for SPECT. You need to have a different setup to be able to do that with PET. And the energy of the radiopharmaceuticals with SPECT are either 70 keV with thallium or 140 keV with technetium. And the spatial resolution is less than what you usually get with PET. And the study duration is longer. So in answer to your question, you can do exercise with SPECT. Right now, the currently available radiopharmaceuticals in the US, we have many of them here. The first two are the ones that are approved by FDA, which are rubidium and ammonia. They both have very short half-life, so making exercise impossible with rubidium, and maybe with ammonia it becomes a little bit, you can potentially do it with ammonia, but it's not done because of logistics that may be a little bit challenging. And the other than that, image quality with rubidium is a little bit inferior. But if you have a newer system, you get better image quality compared to a, for example, older system. And now we have two trials going on. Actually, one of them just completed and published last week using an F18 perfusion agent. So it's not yet FDA approved, but it's currently in the FDA. And there is an ongoing trial with O15 water for FDA approval. So maybe by the time I give this next year, I'll tell you that we have new tracers that are FDA approved. But right now, we're only rubidium and ammonia. In Europe, they use O15 water heavily. And there are a few sites that use O15 water. And F18 radio tracers are hopefully coming up soon when FDA review them. So these are the uptakes. So when you want an ideal radio tracer, you want it to mirror flow. What does it mean? So if there is 1 milliliter per minute per gram flow, and then the flow increases to 2, you should be able to see an increase in that. You don't want it to plateau at a certain number and doesn't increase. And same thing, you don't want it to decrease only beyond a certain threshold. And that ideal radio tracer, that's a board question for you in cardiology and nuclear, is O15 water, because our body is made of water. So technically, you image, you send water, it's just, it will freely go through and the blood goes in the cells and go in and out, and that's kind of mirror. So you should be seeing, even if there is minor reduction in flow, you should be able to detect that. Now, all the other radio tracers kind of plateau at a certain time. So you do not see a reduction in flow or perfusion until there is a significant stenosis. That could differ from one radio tracer to another. So for example, F18 flurpiridaz is going to be in between, like here. It will be between O15 water and thallium. So technically you could see with PET 50-40% lesions that could result in some reduction in flow. You may not be able to see them. Now you cannot see difference between 40 and 20, but you will potentially see a difference between around 50. PET will start to detect some changes. And that's another thing which actually once we get the F18 agent, that uptake is very good. So we might be even able to detect some minor stenosis. So we want to be careful how we interpret them, because we don't want to be sending patients to the cath lab with only non-obstructive disease. So we have to draw a line for that. Same thing for O15 water. They drew a line. They said it is linear, but a significant stenosis by cath lab terms that Victor can educate us about. By cath lab terms, what's significant, 50, 70, means that the flow is reduced below certain cutoff. So if you're above that cutoff, then you may have a stenosis, but it may not be obstructive enough. All right, so we talked about the annihilation and the 2 photons. The other characteristics which is very important for you to understand, and we talk about it and has a clinical implication, is something called the positron range. So when we inject the radio tracer, it goes in the capillaries, and then it goes to the cell and it annihilates. But before it annihilates, depending on the energy of the positron that it emits, that positron is going to travel a distance from here to here. This distance is called positron range. And this is kind of the blurriness of the image, equivalent to your blurriness of the image. So which one has the highest positron range? The highest energy one, which is rubidium. So if I put, for example, a drop of one isotope, you can see the one that doesn't travel a lot is the least energy, and that's the F18. So you can have very sharp, crisp image, and that will have even much better in terms of spatial resolution and delineation of specifics of the muscle that you see there, even papillary muscles and others. Rubidium, because it travels a lot before it annihilates, now you end up with a little bit blurrier images. Although if you have newer machines, the newer machine may accommodate a little bit for that. And ammonia is a little bit less in terms of blurriness, or has a better positron range. So here I'm showing you two images. That one of them is the same patient, rubidium and ammonia. And you can see that the thickness appears a little thicker on that. It's not because the patient has LVH, it's just because the rubidium moved a little bit before it got imaged, so you end up with that kind of a little bit of a blur. This is from our lab, exactly same patient. On top you have rubidium, on the lower you have F18. You can even appreciate the papillary muscle on the F18, which you don't see very well on the rubidium because of the positron range. So that's why the images will look sharper, more delineated, and has better image quality there. So let's dig a little bit deeper on these radio tracers. So again, we talked about O15 water. It's the ideal flow tracer. And first pass approach is unity, which is like almost linear. And again, all studies, it has been initially tested against microspheres, and now whenever you come up with the radio tracer, now you compare it to O15 water in terms of extraction. And the half-life is 120 seconds, so it's not going to be easy to go ahead and do an exercise study for it because it's 120 seconds. So you cannot exercise, inject, and then get the images. So the second one that is approved in the US, it's called N13 ammonia. And this is cyclotron produced. So the half-life is 10 minutes, almost 9.8 minutes. So technically you can exercise patients, some sites do it, but then there's a lot of exposure to the patients, so the staff, because every time they're injecting as if they got the dose too. So sites that do it, they do only selective cases of ammonia exercise. And the dose injected is 20 to 40 millicuries. And then if you're using the same dose, especially if you have an older machine, you have to do rest, wait 15 minutes for it to decay, the 5 half-lives we always talk about, and then bring the patient and do the second scan. Now the newer systems, people are able to do low dose, high dose kind of ammonia protocols that are being able. So it's possible to be combined with exercise, but if you're using an older system and the older protocols, you need to wait 15 minutes between rest and stress. So if you have an obese patient, you cannot do them like while on the same time on the table. You have to do one scan, take them out, wait 15 minutes, put them back again, and do the second scan. Wait for ammonia to decay.
Sir, one question. How do they use in Europe the O15 water if the range resolution is bad and you have low count rate and imaging?
So it's primarily depending on flow.
Mostly on the flow.
So they make their decisions primarily on the flow. They know you don't get ejection fraction, you don't get, and because it goes in and out. Now there is one company that has a software that can, based on the first pass, can potentially give you an image. But again, this is still work in progress. But O15 water, like all these specific trials, that it was purely flow data. And they come up with number, they look at the segment, and they will say this segment flow is, usually they use a cutoff of 2.5, so if it is 1.5, then you think that there is reduction in flow there. So it's pure flow, and again, it becomes a little bit challenging to know which one is epicardial, which one is microvascular. Just got- So with ammonia, to be able to do it, you need to have a cyclotron nearby. So it's a 10-minute thing, so as long as it depends on how far you want to get it in 10 minutes. Now, if you don't have a cyclotron, there is a new solution, actually two of them. One of them is coming up, and there is something called a mini cyclotron, which is probably double the size of the podium I'm standing on. So some company will come, put it on, and they connect it to you, and it will be next to your scanner. So you don't need a full installation of a full cyclotron. So there is a company in the US that have these mini cyclotrons and allow you to put it, and it's FDA approved, and sometimes some sites are already using it. But the most common utilized one is actually rubidium. So we utilize rubidium. You get a generator every 42 days. You put it in the injection system, and the half-life is 75 seconds. And we inject, depending on the machine, you inject between, if you have a very old system, the one I talked to you about, the 2D systems, then you need to have 40 to 60 millicuries. If you have a digital system, we inject 10 to 20. Maybe in bariatric, we can push it up to 25 millicuries, but not more than that. You get good image quality, and you can quantify blood flow with that. So these are some of the images. This is the one that we have, and this is the old generation system from the other company, and it will allow you to inject and get perfusion data with that. And we talked about this. So now, because the F18 have good radiotracer activities, and because F18, what's the half-life of that? 2 hours. So technically, you can produce it in here and send it to Dallas, or send it within 2 hours. All you need to do is produce double the dose, so half of it will decay on the way, and half of it will make it there. So if I do not want to commit to buying a full generator, then I can just go ahead and buy a dose like we do. Like today, I want to do one patient. I don't need to buy a generator and let it decay on my premise. I can just buy one dose, and that's the hope that when this F18 agent got approved. And this F18 agent is called flurpiridaz, currently owned by GE. And if you looked last week, there was a publication in JACC looking at this and comparing it to SPECT. And these are some of the images of this agent. So on top here, you have SPECT image. And this is the same patient. We were part of the study here. And same patient. On top, it looks normal SPECT. And on the bottom, it was abnormal flurpiridaz. So it was a disease. It was a lesion that was missed by SPECT imaging. On the other end, you have here a fixed inferior defect, which could be attenuation artifact. And since obviously PET is attenuation corrected plus better image quality, you can see the differences in image quality. And you can also notice how crisp the images are on PET compared to SPECT, mainly because of the F18 flurpiridaz. So going back to your question, Dr. Duarte, when do I prefer PET over SPECT? I prefer it always, but we have to be realistic. You cannot switch everybody. It's a more expensive test, not widely available, and you have to do some cases on SPECT. So why do we prefer it only? Because it has a lot of additional advantages. All studies that have compared PET to SPECT have shown, or other imaging modalities, including all the other stress modalities, have shown that PET is by far the most sensitive modality compared to others. And it has consistent high quality images. Last week we did our highest BMI patient. It was like almost 76 BMI, and we still got very diagnostic images. and it is low radiation exposure. I didn't show you the data, but when we do PET, it's like you're talking about 1 to 2 millisievert. Even if you have a bariatric surgery, you can go up to bariatric patients, you can go up to 3 millicuries, but not beyond that. Acquisition protocols is very quick, not like SPEC 3-4 hours, or so it's comparable to much of the other faster ones. We're talking about 20 to 30 minutes, and Dr. Toro can attest to that when he was in PET. And we can quantify myocardial blood flow, and we have a lot of data now on this. This week we published our meta-analysis of the outcomes of PET, and now there is outcomes data on PET on almost 60,000 patients. So this is a modality that has been there for some time, and it's not as widely available as we hope for, but I think it's making some breakthroughs. So what do we use this tool for? What do we use this machine for? Before that, any questions about the radiopharmaceuticals before I sum it up? Yes, sir.
So, I mean, I'm just thinking now, that when we inject someone on SPEC, the half-life, this patient when he's walking, he's radiating everyone?
Yeah, so I mean, but you're injecting a small amount. So remember, from a radiation safety, for every step you walk away, the radiation dose is going to come down by one. It will be 1/4 of the exposure, because it's related to the square of the distance. So plus you're injecting these patients with small amounts. So the patient, yeah, I mean, there will be some radioactivity available there, but the amount we're injecting, so we don't want to create a scare. I mean, you're talking about a very small amount. Even that dose that you inject, it is a very small dose that you inject these patients with. But with rubidium, the half-life is 75 seconds, so they're like, by the time they walk out of the lab, they're not radioactive. FTG, the half-life is 2 hours, so they're still radioactive for about, have some radioactivity for about, like, if you multiply 5 by 2, it's like 10 hours or so. Any other question? All right, so all these applications we do with cardiac PET. So we do PET perfusion is now probably about 70% of what we do. But it's not only that. We do viability imaging, we do inflammation imaging, infection imaging, and even like vascular graft infections and others. So we do a lot of other potential applications, and this kind of applications are growing, and now we're seeing almost 30% of that, but it's definitely growing. In Europe, they do, for example, a lot of infective endocarditis imaging. In fact, I know some labs that have just one PET scan that does only infection imaging, like in some of these referral centers. So this is a modality that is underutilized in the US, and now it's like one of those indications. I know we'll cover these more in the upcoming years, so you guys have a lot of dedicated lectures about these, but I'm just going to touch base on a few things. So the first one is the MPI protocol. This is our protocol here. We do it very quickly. It's a 20-25 minute protocol. Because we use rubidium, we inject rubidium. This is the dose, not the dose we use here, 25 to 35. We use more 10 to 20 millicuries. And we use regadenoson. Within 10 to 25, within 20 minutes, we're almost done, and the patient can move around. So who are the patients that we would like to select for PET, since we cannot do everybody with PET, obviously? So if somebody, when you order a stress test, if you note, we put a quality statement on SPEC. So it's a double-edged thing. So when you are reading SPEC and you know that this is not a good quality, put it there. Don't put the image quality is excellent. Put it that this is poor or fair, because there is so much. So when this patient, we do in the US a lot of layer testing, and so when this patient comes back again with chest pain and somebody want to order a test, they don't order another suboptimal study. They will choose another modality that has a good image quality. And this applies to not only PET or SPECT, you can apply it to CT, MR, and echo. I mean, put the quality of the study there. But also, when you are in the ER or on the floor and you have see someone, just look in the chart and see what kind of testing they had before and what kind of image quality they were able to achieve, because that's going to be very important to make a decision about that. So all insurance companies, if you tell them that I had a prior suboptimal image quality, then they will approve a PET. So this is kind of like one of their top indications, because they don't want a false positive. They know a suboptimal study will give them a false positive, and if any additional test will be extra cost to them. So you get that, and it's not good for the patient, obviously, to do another test. You want to choose the test that will give you the answer based on the patient clinical characteristics. So another thing is BMI. Most insurances will approve above 35. One company specific fixes on the 40. And so that's something that you need to, like if you document that, so you can clearly, we want to target these patients, because if you, especially if you do them with SPECT and it's not attenuation corrected, it's not going to be good. And if there is a workup of new onset heart failure, you gather way more information with PET compared to SPECT, and I think it's more, you have to aim more sensitive here, and the blood flow data is going to be helpful. If you're looking for cardiac transplant patients, looking for cardiac allograft vasculopathy, and for young patients, that's my personal bias, because they're going to get 1 millisievert, and I'm not aware of any other modality that will give them this radiation dose other than echo if you're going to be doing it. Or so if you want to get a stress modality that will give you with radiation, I think PET would be the test to go. And then finally, if you have a calcium score more than 1,000, I don't think without blood flow, you're going to be able to interpret these data. So image quality is much better with this information that you get here. You can see the image quality, and this is not from our lab. This is one of the literature with a BMI of 43, and you can see the difference between SPECT, even with attenuation correction, and PET. Now, what do you see here? Stress on top, rest on the second, fourth, sixth, and eighth row. So how would you report it? So for those who have not done their nuclear rotation, so there is, where is it? Yeah, so the donut is missing a piece here, and it's missing both at stress and rest. So how would you report it?
Large fixed perfusion.
So large fixed perfusion defect. You want to add any few more words? Scar, no scar? So when we look at it, so this patient had a PET, so it's a fixed defect. You're right about it. But we really cannot comment on viability unless we've done a true viability protocol. And this is the viability of the patient. So now what do you think? So it's a very viable segment, right? So that's something we need to kind of train ourselves that if you really are looking for viability, do a proper viability protocol. And here you can see a fixed defect could be a scar, but could be also hibernating myocardium, which is what we see here.
We have not done nuclear rotation yet, so can you explain, sir, like
All right.
how do you say it's viable?
So here you see like part of the donut is missing, right? And missing on both ends. Can you hear me here? Yeah, so I'll come closer to you here. So this is the full this should be a full donut, and on stress and rest it's missing. But then when we go ahead and do the viability imaging, you can see that there is some uptake there. There might be some subendocardial scar, but you can see missing, but it's coming back here. So there is significant viability, more than 50% of this. Same thing here. You look at the lateral wall, It's missing, but then you have the uptake there. You have the inferior wall, no, like it's missing there, it's missing here, a nice uptake of FTG there.
Thank you so much.
And if I zoom on it, here it's now should be much clearer. You can see it now for us? All right. All right. So another area where we do a lot of applications, so I'm just going to mention them quickly. We do a lot of sarcoid applications, looking for patients who have inflammation, but not necessarily sarcoid, but could be any other kind of inflammation. This is your case of aortitis, Takayasu. You can see the amount of inflammation that we can see. What is this? Endocarditis. So see on CTA there is this area here, which is hypoattenuation. It's very hot. Even there is another one here which is not well seen here, but you can see. So 2 potential abscesses in this patient. And we not only do it for valves, but we also do it for, now it's becoming a popular one, which is LVADs, because this cannot be well evaluated by other imaging modalities. So here's one patient that have some infection on the outflow cannula, and you can see it also in the distal segment there. All right, so over the year we'll cover many of these topics and more details, each one of them. All right, any questions? Yes, Faraz.
This might be redundant, sir. So how do we know, like a lot of PET scans report for state of the scar. So how can we assess a scar on the images?
So scar, I mean, so when we call it scar, technically we should not use scar unless we've done a viability imaging. We should call fixed defect, like what you see here. So if it is a defect, I know some of us might call this like a scar. It's a fixed inferolateral defect. But technically, unless you do a true viability study, you wouldn't know. So a scar will look no perfusion and no metabolism, because this is measuring metabolism, this is measuring perfusion. This is how a scar will look on nuclear, specifically on PET imaging.
Can we look for a pacemaker or ICD?
Sorry?
Can we look for pacemaker or ICD?
Yeah, for
Can we
infection.
differentiate like a thrombus from vegetation?
I mean, thrombus versus vegetation, I mean, if it's a hot vegetation, you should be able to see it. Now, if it is a partially treated, because remember, if it's an infection, like hot infection, not partially treated, you should be able to pick it up. Where it starts to become muddier when it's partially treated and it's not as effective. So if you're suspecting something, do it early on before. We don't want to hold antibiotics, but if you start treating the patient for 2 weeks, they may not look as hot, and then you have to lower your lower your threshold to call it, but then when you lower your threshold, you lose some specificity too.
Okay.
That's why some of our reports might say could be partially treated infection.
That sounds a dumb question, but
No dumb question.
Can we do it in pregnancy?
So all of these techniques are radiation, so we do not want to do it in pregnancy unless the benefit outweigh the risk. So technically, you rarely have to do a nuclear scan in pregnancy.
What about the agents, the nuclear agents? Are they safe in pregnancy as well?
No, the nuclear, I mean, they are all radioactive. You don't want to expose the baby to any radioactivity.
But is it the same camera that they use when you do the tagged white blood cells? Or the
So what's tagged white blood cell? What do you tag it with? Technetium. So which camera is it? All right. Thank you.